Okay. Right, welcome to this meeting of the Public Services Committee and the first meeting we've had on our new inquiry into medicine security. I'd like to welcome our three witnesses today. I'm going to start by just asking them to introduce themselves. So I think I'll start to my left.
Hello, everybody. Good morning. My name is Dr. Emilia Van Jarrison. I'm a lecturer in Operations and Supply Chain Management at the University of Sheffield.
And I'm Keith Ridge. I guess I'm here because I used to be Chief Pharmaceutical Officer for England from 2006 to 2022.
Hi everyone, I'm Dr. Paul Ongrand-Fady. I'm a Biosecurity Policy Manager at the Centre for Long-Term Resilience.
Okay, and I thought it'd be useful just to start with trying to get an overall view of where we are in this area in terms of the key risks to the supply of medicines. So just sort of a summary, and maybe start with Paul on this one. What would you say, how would you sum up the key risks to the supply of medicines in the UK?
There are three main risks that I'd like to highlight to the committee. The first is overconcentration of supply for UK medical countermeasures and medicines, which are terms I'll be using interchangeably, just based on the jargon that we use in my specific subfield. But overconcentration of supply of medical countermeasures coming from very few countries and from one region. So Asia produces a lot of the medicines that we use here in the UK, and specifically India and China account for a very large portion of the medicines that we import. There are 93 active pharmaceutical ingredients, or APIs, again a term I'll be using, which basically means that the part of a pill that actually makes you feel better. So there are 93 APIs that have no European manufacturers whatsoever, and clearly this presents a risk to our supply chains. The second thing I'd like to highlight is the lack of visibility in the UK supply chain for medical countermeasures, which stems largely from a poor data integration. We have a lot of data and we collect a lot of data in this country at the government level and in private industry. Those databases don't always speak to each other very well. There has been some progress, and I'm very happy to say that the GSCIP, the Global Supply Chain Intelligence Program, which is housed by the Department for Business and Trade, is making some headway in allaying that concern, but there are still improvements that can be made there, especially as regards integration of data streams from different government departments. There still remains some siloing. And finally, the lack of diversification in domestic medicines manufacturing. We don't make very much in this country when it comes to medical countermeasures, and when we do make medical countermeasures, we make very few types, and that exposes us to some risk as well.
Okay, thanks. Dr. Ridge?
Okay, I agree with all that. I guess I'd sort of follow on by saying that, in part drawing on my experience during the pandemic and where I was leading professionally on the medicine supply chain, but also sort of looking at current government policy around particularly documents issued by the Cabinet Office, which Paul is very familiar with, so the National Risk Register, the UK Resilience Action Plan, and the Chronic Risk Analysis, and indeed a document recently published by the Department of Health, which tries to address some of the introduce more mitigations, I guess, in relation to the risks some of which have been identified. But I would say that, and I have confirmed, that one of the things I'm concerned about, and I'd highlight it as a risk, is the government have taken the view not to have stockpiling. Stockpiling is not the current government policy. When I think about the pandemic and the efforts we had to go to globally, and of course in this country, about the global demand for example, medicines which were keeping people alive on ITUs, intensive care units, then I'm worried that there is no policy around stockpiling for critical medicines. And then when you put that alongside what the EU are doing in terms of the Critical Medicines Alliance, so for those of you who may or may not know, a sort of collaboration between public and private sector, looking at supply chain vulnerabilities, thinking about what critical medicines should be, and have generated a list of those critical medicines. And then you sort of look at what the US are doing, put into one side the current debacle around pricing and things, then clearly there are executive orders in place around API manufacture. So coming back to Europe, Germany have 6 months supply, sort of stock holding at manufacturer level. France are doing something similar. So you sort of think we have a policy at the moment. Those documents, I think Paul will confirm, do not specify, those Cabinet Office documents do not specify the medicine supply chain as a risk. To be fair, they do point out supply chains in general. So I guess people like the Department of Health who have the lead here will be following on from that. But overall, I think there are some significant risks generated by the fact that the government have taken a view of no stock holding policy. A couple more points, if I might, because they may be overlooked. There are a couple of specialist supply chains, if you see what I mean, which I think I would draw to your attention. Yeah. One is what's called the aseptic or compounding supply chain, and I know you've touched on this in the past, in fact more than touched on it through the sort of home care medicines work you've done. Lord Carter and I have been heavily involved actually in the reviewing aseptic work in provision in the NHS. So for those of you who don't know, aseptics is where you'll take a medicine. Chemotherapy is a good example, where the dose is very particular, and you have a pharmacy in a hospital or a commercial compounder have to manipulate that product in order to make it suitable to be administered to the patient. Lord Carter was commissioned by government to review this area, and the previous administration, all the recommendations from that report were accepted. Basically, we found that the NHS estate in this area was poor, needed investment, and there needed to be more activity with the private sector to provide these services. Whilst there's been a good start, to sort of in terms of implementation, that has certainly slowed down with the new administration. So I just bear in mind that with chemotherapy, 5% annual increase a year, then the sort of modelling within NHS England is essentially saying that by 2030 there won't be sufficient capacity to deliver chemotherapy in England, and I think that's a concern. The other specialist area is around radiopharmaceuticals, which often again gets overlooked. Critical to both diagnosis and therapeutics in some areas. The estate in the NHS is not what it could be, and this again presents a complex supply chain depending on things like nuclear reactors and things in other countries, and there have been shortages in the past around this. And those two specialist areas, alongside the sort of main general supply chain and the risk I've highlighted, particularly around no stock holding and no real identification in Cabinet Office documents that the supply chain is a risk. So I don't know if that helps as an initial. No,
it does. Thanks very much. And Dr. Van Jarison, anything to add there?
I have like two major things to talk about. First of all, the pharmaceutical supply chain as a whole in the world are all interconnected, and we have peculiarities about them, such as we have limited manufacturers all over the world that manufacture for an increasing population of people. And so when we have all of these limited capacity, limited manufacturers, and then we have peculiarity in the UK where procurement is 70% by the NHS, and then pricing, reimbursement strategies, it makes it very difficult to make the UK resilient where we're looking at cost efficiency instead of resilience and flexibility. So those are the two things I would like to highlight.
I just got one follow-up question before I bring in Lord Bencather, because he's got a supplementary. Am I right in picking up from what you've said that the situation in the UK is worse than it is in some other developed countries? Is that a correct summary from what you said?
Just because of its peculiarities. For example, if we look at Germany or we look at the US are more competitive. So we have manufacturers that will be willing to manufacture based on price. For in the UK, for example, because we have price cap and then the NHS is always like trying to, for more cost efficiency, so you leave limited manufacturers within the economy to be able to compete on price. And so when there's a shortage of a medicine for you to find the second person or the second manufacturer to come back and say, okay, we are going to supply, will take a long time. I remember that manufacturing of pharmaceuticals is very stringent. The regulation is stringent. The passing into law or getting people to manufacturers to come into our economy, it takes a longer time. So if there's a shortage, the bounce back, that's that resilience that we're looking for. It's an issue, and that needs to be addressed.
Lord Blencathra.
Thank you, Chair. Lord Blencathra, I have no interest to declare.
Oh yes, I've no interest to declare either, sorry.
We've read here, and I think you've said, that China and India dominate the world market for APIs at over 80% of production. How has that come about? Have they got unique pharmaceutical brilliance, or is it access to natural resources, or is it cheaper production costs? How have they come to dominate the world?
I'd love to jump in first with them. Part of it is, well, most of it is lower costs for manufacturing and historical lower costs for manufacturing. So energy, labour in particular have been historically low in China compared to the UK. There was a sort of big campaign of offshoring that began in the 1990s that was quite intentional by private industry to lower costs and therefore increase profits. And this was seen as a really positive thing at the time, with no view for the long-term resilience of the nations within which they were initially manufacturing. The issue there is that it's incredibly difficult to then reshore. It's possible. It takes specific political will and an expenditure of, political and financial capital. And I've spoken to a number of experts who oversaw at big pharmaceutical companies that offshoring process. And something that they've pointed out is that the offshoring initially began because of these lower cost burdens. In particular, I think it was something like 8% of the cost to manufacture in China compared to the UK at the time, on the basis of power and labour combined. It was 8% in China compared to the UK. They've said that the main issue is that there's been an erosion of the heavy industries that support API manufacturing, which then makes the reshoring much more difficult. So, as an example, it used to be the case that ammonia was manufactured in the UK, liquid ammonia, aqueous ammonia, which was used in fertilizers, and it was also used in parts of the medical countermeasure manufacturing process. It's just one of those things that you could use for both. As the UK moved away from using aqueous ammonia in farming, for completely unrelated reasons, those industries shut down. There was no longer a need for medical countermeasure manufacturers because they had also gone. So there's no aqueous ammonia being manufactured in the UK. So even if you wanted to bring back the API manufacturing that relies on that, you don't have the feeder industries. So it's not as simple as saying, okay, well, we make this pot of money available and we'll draw back manufacturers. There are entire industries that feed into that are lacking. And so it requires a sort of really distinct political will from the centre to say, this is something that we value, this is something that we think is important. As a result, we're going to make sure that we have every piece of the puzzle in place in order to bring back those manufacturers.
We'll leave the follow-up questions on that to question 4, because we've got a question in its own right on that. So thanks for that. But I think I'm inviting committee members not to follow that up until we get to question 4. And responses on the...
So economies of scale. So manufacturers all will want to stay in India and China because it's cheaper. And then if you have so many manufacturing firms together, we can feed on our knowledge. And that's why all manufacturers want to stay in China first, because they have the key starter materials as well that feed into APIs. So they want to stay in China first and then export because it's cheaper. So that's one of it. Initially, we used to manufacture the product here, but when it became cheaper, and then demand for pharmaceuticals, because people are getting more aware of pharmaceutical products, so demand for it is started increasing. It made sense to go to China and India. But however, COVID showed us something else.
I'd just add that we've been very successful in driving down price. And we've reaped the rewards of that over many years. And I can remember in 2010 when we decided that it would be good to secure the supply chain a little bit more as a consequence of driving down price. So we established something called the Essential Medicines Buffer Stock. And that was put in place across a quite considerable range of medicines, with about 3 to 6 months supply of individual products, where essentially government paid the storage costs. It was a buffer stock, so it was rotated through the system. For one reason or another, mainly cost, that was removed in about 2018 of that sort of 2019, not long before the pandemic. Fortunately, there was some left still, but one way or another, I think, just to add to what people have said, is that we have successfully driven down price and reaped rewards, but that has meant, one thing I should have said right at the beginning, of course, the sort of current geopolitical situation, is clearly a big risk to these complex supply chains.
Lord Bradley.
Morning, and I have no interest to declare. So, how do medicine shortages currently affect patients? And what is the current level of risk that patients may encounter?
You'd start that? Yep. So I'd say it depends. On the one hand, having spoken to the current Chief Pharmaceutical Officer for England, there are 3 coroner's reports which seem to be related to medicine shortages. At the other end of this is that if a patient is unable to obtain a medicine, then obviously it's a lot of concern for them personally, and of course that typically, if you take myself for example, I'm on 2 generic antihypertensives. If one was to go into short supply, then either another supplier of that antihypertensive should be able to be found, or it'd be quite an easy-ish thing to switch from one antihypertensive to another. But for some medicines, there are you just cannot do that. And indeed, one of those coroner's reports is about a patient who was unable to obtain anti-epileptic medicine. And I think being able to switch it's very difficult to switch between anti-epileptic medicines. So there are a range of those types of medicines where it'd be really very important, I would call them critical medicines, where we have a resilience in the supply chain. But there are others where this is not to downplay it at all, where it develops a high degree of inconvenience and anxiety, I guess, amongst patients. Overall level of risk, well, I guess most people receive their medicines most of the time. So I think overall, it feels to me that the level of risk is, not as high as some would think. But there is certainly potential, I think, because of the issues we're describing and the mitigations which are and are not in place are not in place as to sort of heighten that risk. But there certainly are examples of from people from fatalities through to people being admitted to hospital through to the full range of consequences.
Okay. Can I add that there is currently no data that captures its impact on patients? Okay, so sometimes if I am a patient and I go to the pharmacy to get medicine and I don't get that medicine, there is no data to capture that I am anxious or I go home looking for. And we have instances where sometimes when you ration medicine for a patient, they go on the internet because there's panic buying. They go on the internet, they try to buy from on the internet, and sometimes counterfeits infiltrate the supply chain through that. So anxiety is one, it hasn't been captured. Counterfeiting infiltrating the supply chain hasn't been captured, and its impact. So sometimes we wait to see that there's a death due to a shortage, and we call that a risk. But there are other different types of risk that are involved. Or even changing the color of the medicine. Some patients, I'm used to getting green, and then tomorrow you give me blue. Yeah. What's happening? But from the upstream, they have been able to mitigate the impact. But to the patient, you haven't. You are giving me a different color. or you're giving me the same but in a different formulation. So take injections instead of a tablet. So there's no data that has been able to capture this, and so we cannot accurately say that, measure the risk involved.
So I think you've answered my follow-up question. There is no measurement of the impact on patients, so there isn't a system to improve.
Yeah.
If we can just come in very briefly, there is no systematic way to capture this data, in answer to your question, and backing up what Dr. Van Jarrison said. I will say that the British Generics Manufacturers Association, now Medicines UK, have commissioned polling on an ad hoc basis, so it's not systematic, it's not something that you can track over time, but it does provide snapshots, and some of that data says in 2024 a public poll by BGMA, so Medicines UK now, showed that of all adults who've had a prescription in the past 2 years, 49% experienced some form of shortage or delay while trying to access medicines. So that's half of the people who've had prescriptions. Of those impacted, 1 in 6 went without their medicine altogether. What impact that has, what the risk, I'm not competent to say, but that is some data. The Pharmaceutical Journal's annual salary and job satisfaction survey revealed that 68% of pharmacists felt that shortages have put patients at risk in the previous 6 months. 68% of pharmacists. Again, they're more competent and qualified to say what that means. And then in terms of trends in shortages over time, as of March 2025, 31% of generic medicines had been in short supply for over 12 months. Over half, 52% of generic medicines had been in short supply for 6 months. But overall, I think we should remember that as a percentage of generic medicines classed as high impact supply issues, it's only 0.09%. So it's not, as Dr. Ridge was saying, that there are workarounds, there are ways to mitigate the impact. So the risk should be kept in proportion. But again, the Medicines UK have said, we track NHS England data monthly and are now seeing twice as many medicines experiencing shortages as there were 2 years ago. So again, I'm not qualified to say exactly how that translates to patient risk, but that's some information that hopefully helps inform the committee.
Thank you.
Right. Sorry. I've got nothing to declare. I'd interpret actually what you said, Dr. Ridge, by actually suggesting the risk is very low. But going further, and I appreciate risk is always a matter of judgment, I don't quite know how much of medicine that's prescribed is actually discarded. Yeah. How much of our stock is discarded because of lifetime. Yeah. But there's been this constant thing for a long time that we cannot return medicine and it cannot be reused. Is that not just a waste when we're considering about supply shortages?
Agreed. Okay. There certainly is wastage in amongst that, and I guess the sort of general figure that people use in terms of adherence to medication is 50%, is the sort of general figure that people use, and from the literature, particularly in primary care is what I'm talking about here. In terms of return of medication, there are some schemes around the world where in certain parts of California, for example, where returns do actually take place. But here we have taken the view, or the MHRA to be precise, have taken the view that, from a licensing point of view, that the medicines would not be suitable for reuse because of there's no guarantee in how they've been stored.
That will vary, I guess, according to medication to medication.
Yeah. In hospitals, there is more reliance on how medicines have been stored, and therefore, typically, a hospital pharmacy does have a sort of recycling type of policy. But within primary care, they're not. The other thing to bear in mind, of course, is that the sort of community pharmacy reimbursement process and how that happens and how that would be managed if things were returned to a community pharmacy and reused.
Lord Chipley.
Ask Dr. Ridge a question, because he used a phrase that I didn't understand, which is an essential medicine. I think on other occasions the words can be critical medicines. Is there a list? Do you have a list of an essential medicine?
So when we developed the essential medicines buffer stock in around 2009-10, the basis of that was the WHO's essential medicines list, which is what it says on the tin in many ways, the sort of a list of from a WHO point of view, of medicines which they would see as every country should have routine stocks for. Okay. From a critical medicines, sort of to use that terminology, I think that's a sort of subset of that. And so I've mentioned some which were deemed that type in the pandemic, so for things which enable people to be ventilated. But there are, I think, on the EU's critical medicines list, something of the order of 600 medications of that order. Does that help?
It is helpful.
Yeah.
It is that there clearly are internationally recognised, as I understand it, definitions of the words essential and critical.
Certainly essential. The critical is becoming more recognised, I think, in terms of
the obvious reason that what is essential for one person may not be essential for another person,
yeah.
or what might be critical for me as an individual. Sorry, and I have no interest to declare. May be for somebody else.
Yeah.
Less important.
From a government point of view, in the UK, there is no current critical medicines list.
Right. Okay.
Okay. Adlaming.
Thank you, Chair. I have no interest to declare. I wonder if I could just follow up on Baroness Coffey's question, which is that about waste and about return, because my colleagues know that recently I went into a local pharmacy. I was only going to get some sticking plasters, but while I was waiting, I noticed all these racks of prescribed drugs, all in their paper bags, ready to go, you see. So I said to the lady when I got to serve, "You've been extremely busy this morning." And she said, "Why do you say that?" And I said, "Well, all of this medicine." And she said, No. That is people who go into the GP next door, come out of the GP, come straight in the pharmacy, give us the prescription, and then they don't come back to pick up their drugs. And I wondered, following Baroness Coffey's point, you mentioned that we can do some recycling, as it were, in hospitals, but can we do it in GP? I was absolutely astonished by it.
Wow.
So I would also add that I would say that the majority of those medicines are probably going to be repeat medication, and that they're waiting to be collected. Admittedly, some won't ever be collected, but I think the majority of those will be repeat medication, repeat prescriptions.
Let me just explain. When I asked the pharmacist a bit more about this, she said to me, waste is part of our life. We have to keep those for a certain period of time, and then when that time has elapsed, we just get rid of it. So whether they were repeat or not, she said there's a large proportion of medicines that are prescribed but which are never collected.
Well, I'm not here to defend community pharmacy or indeed patient behaviour at that point. I would say that the recycling issue in primary care is more difficult to achieve than it is in secondary care for a whole range of reasons, including reimbursement.
Okay.
Before I go on to Baroness Cass for the next question, can I just go back to the Care Quality Commission? When we were talking before about whether we know about whether there's harm done, we've had a letter, part of our evidence from the Care Quality Commission, so they've got some responsibility. And what they were able to give us was examples of medicines where there have been shortages in a similar way to you did in the opening comments. Do they not have a responsibility to investigate the impact of that? So if I frame the question this way, what is the responsibility of the Care Quality Commission in this area? And is there any other regulator that has any responsibility in terms of the impact on patients? And just to tag that on, would it not be recorded as an admission to hospital if the reason for the admission to the hospital was the failure to provide the medicine outside of hospital?
It could possibly, it could certainly be recorded.
It might be recorded.
It could be recorded. Whether the data is collected centrally or not is another matter altogether. In relation to regulators, so yes, the CQC would have a role, in my view at least. Bearing in mind I'm no longer the Chief Pharmaceutical Officer, so bear that in mind. So yes, the CQC would have a role in terms of investigating particularly sort of obviously poor quality care. The General Pharmaceutical Council, the regulator for The pharmacy profession and pharmacy premises would have a role as well in terms of the if there was a particular issue about pharmacy professional practice or something to do with how the pharmacy itself had, so it's the owner or whoever had behaved. So there are a range of regulators. The MHRA, I guess, if there was is something to do with in terms of the safety and use of the medicine itself. So there's a range of regulators which I think have a role in this area.
Guys have had something like home care medicines again, this isn't it? Baroness Cass.
Thank you. I've got no interest to declare. Just before I come on to my question, I think maybe we have been conflating some things in the conversation, because there's current harm, and then there's risk of harm, and the risk of harm is kind of related to two things. You know, one being the likelihood of a supply interruption, and the other being the impact of that particular interruption, which is going to be different if it's an essential or critical medication. So I just think we probably just need to unpack that a little bit. Anyway, good to see Keith again, who we worked together when I was president for quite a while. So, so with that in mind. Clearly, as you said, most patients get their drugs most of the time. So obviously the system, despite how fragile it looks, does work for the most part. But could you just talk a little bit about how effective the current policies are across the supply chain at either preventing or responding to medicine supply issues?
Happy to jump in first.
Yeah.
There are three policies and initiatives that I think are worth highlighting. I'm going to focus more on sort of the manufacturer end, because I think that others on the panel are better suited to talk about the patient-facing side of things. So looking at the manufacturer and R&D and developer kind of end of things, there is a fund called the Life Sciences Innovative Manufacturing Fund, or LSIMF. It does what it says on the tin. It tries to stimulate innovative manufacturing in the UK in the life sciences sector. It's £520 million. We are delighted that this money's been made available by government. Industry has been very welcoming of this fund. It's very easy to apply to. Everyone that we've spoken to thinks it's very well administered by the Office for Life Sciences, which is great. I would just like to draw the committee's attention to the size of that fund, which is £520 million. That's a lot of money, objectively. But the cost of COVID was £400 billion, which is 1,000 times higher. I'm not for a moment suggesting that £400 billion should be invested in life sciences manufacturing. That is clearly far too much. However, I think that if the government is really serious about wanting to safeguard the UK against biological risks and threats, then the scale of the commitments need to match the scale of the ambition. £520 million is a great start, but perhaps it would be worth looking at how that fund could evolve over time. That same money has been announced on a number of occasions. I think the fund was first announced in 2022, and successive governments have, on a number of occasions, said, we have £520 million available, we have £520 million available in 2023, 2024, and 2025. That fund hasn't changed size over time to match the scale of the ambition of the government in its, as set out in its industrial strategy, life sciences sector plan, for instance. So I think that there's some thinking that needs to be done around how that fund evolves. And again, it's a great start.
Sorry, what's the scope of use of the fund?
It's for, as it says, innovative manufacturing, so novel technologies, novel processes for manufacturing, more efficient, more automated, Industry 4.0, which is the integration of AI into manufacturing, novel modalities of therapeutics, so nucleic acid-based drugs, so quite a lot of quite cutting-edge stuff, which is great. The other aspect, which I wasn't going to highlight, but I will in response to your follow-up, is that innovative manufacturing is good. Basic manufacturing is also good. The kind of stuff that we offshored to China in the 90s was not super.
That's a strong point.
Just would you mind if I did? So I'm glad you've highlighted that, because one of the risks I could have highlighted is the sort of balance of policy between innovative branded medicines and generics. Generics are 80% of what we dispense, certainly in primary care, are used or prescribed in primary care. And it's at least the same, I would have thought, in hospitals of that order. But the sort of focus of attention is often, particularly in medicines policy-wise is particularly towards branded, innovative medicines, as we have seen in the recent press associated with medicines pricing. I'm concerned about that, particularly in this area, and mention of that fund. Now, that is part of the pricing arrangement, and at the moment, and is open to all. And in particular, there are certain generic medicines which actually get not very many, but they get captured for one reason or another in the pricing arrangement. And those medicines are called biosimilars, and those medicines are really very important. They're complex molecules, treat important diseases like rheumatoid arthritis and ulcerative colitis and various other things, are very effective. But when on patent, they were very expensive. Now off patent, as biosimilars, they're about 80% cheaper than they were when they were branded. Now, since that part of the generics industry are contributing towards you would have seen in the press the payment, I think, which is associated with the scheme, then surely, and given that biosimilars are largely manufactured in the Far East, why wouldn't sort of some of that fund be, as we sort of head towards reshoring, why wouldn't some of that fund be used to start to develop manufacturing of biosimilars in this country, rather than being reliant on Far East and complex schemes in a sort of rising problem geopolitically?
So we're going to come on to reshoring and nearshoring with Lady Coffey's question. So maybe if we could look at the other aspects of prediction and mitigation. Yeah.
And Jarison, let me just bring Dr. Van Jarison in first.
Okay. Thank you so much. So in terms of policies and trying to predict shortages, the issue is that it can be done. That's the good news. But the problem is our fragmentation of data. So we have different offices that are doing different things and they don't talk to each other. Yeah. So we have the MHRA that is looking at licensing and security. We have DASH for manufacturers. They have to report shortages, and those reporting of shortages, it's supposed to be mandatory, but they don't, and then it's lagged. So there's no time. There's no real-time visibility of their manufacturing. And then we have also the NHS England, and we also have community pharmacy, which also have their own data. So everybody has different pockets of data and nothing is talking to each other. And so the ability to use real-time data to predict when a shortage happens, it's a problem. So we also have issues with all the other things that are around the world that are also influencing, because according to our research, we've seen that if a shortage happens abroad, there's a likelihood, 70% likelihood that that shortage will happen in the UK, just to show you the interconnection between all of these things. And so if we have our data talking to each other, we're able to better predict if there's a shortage, yes or no. Another issue is that we don't have a unifying umbrella that overlooks this. So we're doing our research and we're saying, okay, if we have AI models that are going to help us predict shortages, who is going to be in charge of that? Where's the data coming from? We have the GP, they have their data, prescribing habits, but we don't know what its impact on demand. We can't see that, so we don't know what is happening there. Then most of the data that comes from the Department of Health or that comes from the DASH, for example, is just from the manufacturer, and we don't have community pharmacists or community pharmacists basically reporting a shortage into that. And so by the time we're planning or we're trying to react to a shortage, it may already have happened, it would have happened, or sometimes it's reactive instead of proactive. So we need like a single umbrella that can help the policies in place. The policies in place are okay, but the main thing is talking to each other, getting all of these data with each other, and then having an umbrella view of how these things interact from abroad and within all the stakeholders.
What do you think we should actually have if you were in charge of, the policy on it, would you have a new body that was responsible for pulling all this together and being a medicine security sort of organisation, or should one of the, or maybe one of the existing ones should take that? But is that what way?
Yeah, if we have like a unified, I know that the NHS digital supply chain, they are trying to do that, but the fact is that it doesn't. Because of the different infrastructure, everybody uses different infrastructure. And so we need to bring all of this infrastructure, update the infrastructure and bring it together so that we can have a single body, new or old. It just depends on who has the capacity, who has better capacity to do that so that we are able to predict better.
The slight heart sink in our briefing was the thing that, if we had the perfect unified database, then it becomes a cyber risk. So it's a sort of rock and a hard place.
Another issue is about confidentiality as well. There's something we should look at confidentiality when we're talking about data as well. So if we're looking at everybody reporting, some manufacturers may not want to report or expose, like my colleague said here, visibility. I don't want you to see how far, where am I getting my APIs from? I don't want you to see. So I will just report by email or just show you a part of it. And then from the patient aspect, which we're not even looking at, and we're not even integrating from the community or even hospital pharmacy or the GP, we're not looking at that. So what aspects of that data are we going to integrate into that? We need to think about all of that as well in confidentiality.
I could make a comment further on data if that would be helpful, or on how we currently respond. But on data, then so in my view, this is pretty grand, but the drive towards supply chain digitization is what we're talking about here, I think, and the sort of from manufacturer through to patient, essentially. And at the moment, so in hospitals, largely because of what we had to do during the pandemic, we do understand where stock is in hospitals if we want to do that. But in primary care, we just don't know. And so there was, prior to coming out of the European Union, there was something called the Falsified Medicines Directive, which people may or may not be familiar with, but essentially a barcode on a pack, which is being deployed across Europe, where products can be scanned in and out of a supply chain. And if you go to European pharmacy in Europe, you'll see this happening in real life. Now, once we left the European Union, then there was a commitment from the previous administration that there would be a UK version of this developed. I've not seen that commitment with the new administration. And in my view, and indeed it was something I was going to suggest to you, is that there is a case here for reintroducing something like the Falsified Medicines Directive across the UK, but as part of a supply chain digitisation process. If you look at the range of automation and various things which can be deployed in hospitals and elsewhere, the data there, together with data which sits at wholesaler level and at manufacturer level, could be brought together, and that barcode, which would be on a pack, is probably central to all of it. So I think, therefore, the Falsified Medicines Directive, a new form of that, is important in my view.
Well, did you want to come back in?
On the data integration and transparency front, I think is really a great segue into some of the other policies which are and aren't working. There are other countries where, so New Zealand, for instance, MedSafe is the equivalent of the MHRA. Their database has free for the public to see very easily by just simply looking up the medicine, the origin of the API, where it was processed, where it was packaged, and who shipped it. All of that is available for the public to see as a matter of course. We have that data as well here in the UK. It's just not made available to the public or to anyone else for third-party scrutiny, whether academics or civil society who want to, run a third-party analysis, or for the government itself. I think that that's an oversight and something that could be quite easily fixed. Again, if it's data that we have and that we can integrate, that's easier than collecting the data in the first place. Similarly, we published a report a few months ago entitled "Growing the UK Bioeconomy," and one of the things that my colleague who led on that pointed out was that the funding for people who, and that could be startups or it can be legacy or innovators, people who want to get involved in helping plug gaps within the life sciences supply chain, the funding is atomized across a huge number of funders, whether it's UK Research and Innovation, whether it's Innovate UK, whether it's the Defence and Security Accelerator for people who are taking more of a national security angle on it. All of these pots of money, which are available to innovators, are just completely spread out across the entirety of government with no centralized data platform to be like, okay, here are all of the opportunities available for people who want to get involved in manufacturing to plug gaps in the supply chain, which is, again, a fairly low lift, but quite helpful in centralizing and streamlining the access to that data for people who could really make a difference in this space. So I think that it's a cliche at this point to say that data is the key to unlocking a lot of efficiencies, but in this case, it's data that we have. It's not a huge ask to say, let's go out and get a ton more data and try and figure out ways to analyze it. It's just building very basic platforms that enable high visibility, high transparency. The end-to-end manufacturer to patient, of course, is a lot more complex, but I think that with sufficient political will and effort, it's definitely tractable.
Maybe you wanted to come back.
Something to bear in mind, especially if we're talking about medicine security and medicine shortages, it's a unifying definition among all tiers in the supply chain. So, because if everybody's reporting of a shortage, sometimes the pharmacist's idea of a shortage is a manufacturer's idea of a stock out. So those things, we need to have a unifying definition. So, for example, I think last year or 2 years ago, we had HRT shortage, and it was, the pharmacists saw it 6 months before the time. They were reporting it. But however, at NHS level, at Department of Health and Social Care, the manufacturer said it was enough to go round. And so they, in their own view, was a stock out. But for a pharmacist, is a short. So a unifying definition of what actually, among all tiers, is important if we're going to create a database. Because what I will be reporting as a shortage may be a stock out for them. Yep. And so a unifying definition is very important.
Thank you. Okay, thanks very much. Baroness Coffey, can we go on to the next question, please? Thank you.
Sure. There are over 14,000 licensed medicines in this country. The government's recently appointed 4 Crown representatives to be the kind of working with suppliers. And I'm interested in what you said that already generics are about 80% of what is dispensed. So that's by volume, I assume, rather than monetary value. So we've talked here about a number of activities. If we were to reshore or nearshore, how would you decide what was the priority and what are we actually capable of doing?
Sure.
Okay, so firstly, I think reshoring should be part of the ambition. That's the first thing to say. As difficult as it might be, but I think it is an important part of the ambition. On the critical medicines, then that list, that could be generated in the UK, or it could just simply be using the same one that's been generated already in the EU, and that, I think, would then begin to define what, in order of priority, what should be manufactured in this country. So if I turn to my experience during the pandemic, and the critical medicines which were keeping people alive on ITUs, to allow them to be ventilated and so forth, and the global demand for that, as I've mentioned earlier, then a healthy sort of stockpile of those types of medicines, in the thinking about the geopolitical risk or planning for another pandemic or whatever it might be, strike me as being important medicines to be on that list. But there'll be half a dozen probably compared to the 600 or so which are on the EU's list. But I'm sure each of those 600 could be justified. So a process by which that list is generated to meet UK clinical practice. And that could then begin to inform what manufacturing, the priority in terms of what manufacturing was reshored, in my view. Does that help?
Sure. Any contributions from Dr. Harrison?
For reshoring, I just think it's one plug in trying to make the supply chain resilient. So it's a good thing. We can look at cold chain, for example, that takes a longer time from the manufacturer to onshore. That's an important one, but it's just one plug. But we need to also think about the economies of scale. Do we have the key starter material? Do we have all of these things here when we're thinking of reshoring? And then when we think about nearshoring, we need to think about who are we nearshoring to? What country are we going to be looking at? I know that in the EU, for example, they are looking at, Germany is one of it, they are looking at Poland to near shore. So Poland is becoming the next powerhouse for pharmaceuticals. And then in the US, they are looking at Mexico and all of that in terms of nearshoring. But we need to have, who are we going to nearshore if we're talking about that, if we don't have the capacity? And then if we're nearshoring, we also, like I said, economies of scale. If we're going to sell as well, who can benefit from it? So it's just one plug to make us resilient, but we need to think about every other thing. So in my own view, if we're going to nearshore, I know that we had a meeting in November where we said, how will we start? What critical list are we going to go to? And I know in Norway, they had like a stakeholder meeting trying to get the list of, because there are so many. We have 600, we have 800, we don't. So in my view, I think that things that need shorter supply chains where we can see visibility should be nearshored. So like cold chain, things that you know that in 2, 3, 4, 2 weeks, they're going to reach their expiry date, should be nearshored. Those kind of things should be brought. Then others we can, onshore rather than others we can think about nearshoring. Because getting that exact list of critical medicine, you'll see that will end up going to 2,000 or 3,000, I think.
Anything from Dr. Fardy?
Yeah, I would agree with what's been said so far, but I would add that a key component to this is supply chain mapping and figuring out where there is multiplicity of supply already. So just to take one example, gentamicin, which is an antibiotic that's used to treat, for instance, meningitis, but many other things. NHS England did an exercise a few years ago, I believe it was in 2017, to look at its gentamicin suppliers and said, this is an important antibiotic, where do we get it from? Okay, we have 7 formulations available to us in NHS England. Oh, okay, there are 2 manufacturers for those 7. One of them makes 5, one of them makes 2. And they're both co-located in one city in China. So thinking about multiplicity of supply across geographies and thinking about, okay, we have the list of essential medicines and maybe they're also ordered by how rapidly they'll expire after manufacture, but also if we currently where do we currently get them? And if it's only from one place, that should perhaps bring it up the priority there. So I think there's a geographical consideration there. The other thing I'd say is that for total reshoring from every expert that I've spoken to, just mathematically simply isn't possible. We couldn't reshore absolutely everything that we need. Total autarky for the UK manufacturing every medicine that would go into the NHS is not possible, nor is it necessarily desirable in a sense, because fragile supply chains are those which are too atomized and those which are too hyperlocal. If we were to only ever rely on things that are made in the UK without multiplicity of supply from elsewhere and say, no, we'll make absolutely everything and we'll only use the medicines we make, that's just as fragile as not making anything. So it's about diversification of supply with strategic allies in the region in particular to reduce travel time. And I think that comes through a joint DHSC, DBT, FCDO exercise in international diplomacy to try and coordinate industrial strategies across the life sciences.
I was struck earlier at the beginning of our evidence session. I think Dr. Van Jarrison talked about how America had a lot more competition. And then I think it was also Dr. Fardy who talked about the cost of production in the UK as one of the barriers. Mm-hmm. So just thinking that through, obviously all these things come at a cost or a price and balanced against the risk register. So it'd be useful to understand in terms of if we were to make recommendations, what would be, we've heard about different medicines, EU could be a starting point, but what ultimately is going to be the rate determining step? What's going to be that critical success factor? Yeah. Because currently the government has taken a different path. So how can we persuade them to perhaps go back to the path that was trying to address some of this?
Rate determining step comment is very typical of a PhD chemist. But I think we've seen for matters of national and international importance, like the war in Ukraine, for instance, that there's a coalition of the willing that comes together and commits political and financial capital towards achieving an aim. and that aim is, in this case, the security of Europe.
Like we did on getting a vaccine for COVID, the whole world worked together.
For instance. So there are examples to draw on that are not within the defense space and that are within the life sciences. But I think that drawing that analogy with the current defense situation to say that biological security is national security. It's all well and good to defend the homeland through kinetic means, and that's something that the UK has decided that it wants to prioritize. We also have to be open to the idea that we should defend the homeland from biological threats, and those can be natural, accidental, or deliberate. And we cannot be in a situation where funding is allocated only to defense. And I think that there's a real energy to draw on right now as countries come together in these minilateral organizations, which is mission-driven and trying to just achieve outcomes, to say who are our strategic partners, both within the region but also within the wider world, who are our allies, who are our partner nations that are making investments that strategically work for us. Austria has spent 150 million euros in investing into third-generation cephalosporins, so antibiotics. They have the last European vertically integrated supply chain in Austria. Great. Let's see how we can procure that from them. They're our friends and allies. And what can we build so that when they need something, we're not also building third-generation cephalosporins? France has put 7 million euros into building a paracetamol factory in the southwest. Amazing. How can we get paracetamol from France rather than duplicating effort and also building a paracetamol factory here in the UK? There's strategic industrial strategy coordination to be done across our allies and partners in saying we can defend the region and we can defend the country from biological threats.
One final question. Obviously, the COVID inquiry is still underway. And I was mindful, admittedly, doing a bit of research on this. After the 2009, the inquiry into the swine flu, the government of the day, the blue and yellow one, decided to stockpile, I think, or perhaps it was Labour that initiated it, to stockpile Tamiflu. That was then later criticised about why we were stockpiling so much. So where's the balance that you think that we can get to on making of trying to understand what is really key to stockpiling?
It's needed, it's good. If it's not, it's wasted.
I was particularly struck by what you said, by the way, about the chemicals, about keeping the ventilators going.
Yeah.
But,
So I guess I was around that, all of that, as well. There's like Liam Donaldson and the like. And I guess there's a sort of a public health type of argument that was made at the time around Tamiflu. And indeed, with the antivirals with the current or the most recent pandemic. And so, a case can be made on a public health basis to stockpile medicines like that, and the public health professionals will make that case undoubtedly. But in an acute medicine sort of side, then I think the case is a lot easier, in my view, to ensure that there are essential medicines, critical medicines, which you would want to have around at a time when there are particular issues arising around the world, or such as the ones I've listed, but there will be more. They are different from a public health measure type of thing. Now the case can be made for both, and the case for Tamiflu was made at the time, but that comes with risks, as we saw. I think the other thing about the medicines I'm sort of suggesting is, of course, they could be rotated through the system in normal way because they're used in normal practice. Whereas with Tamiflu, then its sort of use is not really, as an example, is not really routinely used throughout the year. There is a process by which antivirals are prioritised as the influenza rate gets to a certain level. But one way or another, these aren't routine medicines, in my view, as compared to the ones I've mentioned.
Thank you.
Baroness Pidgeon was going to come in on this.
Yes, I have no interest to declare. We had been talking earlier about manufacturing APIs, and Dr. Vardy, you explained why it was far more complex. But we've had evidence from the International Pharmaceutical Excipients Council, and they talk about 1,200 excipients used in medicines. I'm wondering about, is that an area we could be focusing manufacturing on to make us resilient, and sort of linking with the sort of description you were and the picture you were painting of Austria and other countries and how we could share?
It is, but it's a support function. So excipients are the part of the pill that don't make you better, right? The pills are physically made up of the active pharmaceutical ingredient and the excipient.
But you need all of it.
But you need all of it. You do need all of it. I would say that...
It's quite strong, their letter. Maybe this is a bit I haven't realised as well.
I'd be keen to see the evidence once it's published by the committee. I think it would be very interesting reading. It's certainly a way in which, as part of this international coordinated industrial strategy, if the UK were to decide, as Dr. Van Jarrison was saying, to turn into the powerhouse of excipients, perhaps that would be an avenue to make attractive deals with foreign nations that are making the active pharmaceutical ingredients. I have to say it's not something that I've considered very closely, but it's an interesting idea.
Are they easier to manufacture?
They also rely on key starting materials that we largely don't make. So we have the same sort of issue.
Same sort of issue.
And they also rely on heavy industry in a similar way. So I would say no, not much easier than active pharmaceutical ingredients. And if you were to stockpile them, there's no... I mean, it would be useful in... The UK does a lot of fill and finish manufacturing, which is to say sort of that last step. We don't make the active pharmaceutical ingredient, but we will take an excipient made elsewhere, an active pharmaceutical made elsewhere, combine them together into a pill, and then we sell that pill. So the fill and finish step is something that the UK actually does quite a lot of, as opposed to any of the sort of further upstream manufacturing. I think that with the security lens on, I think people would feel more comfortable in that investment if it was an active pharmaceutical ingredient, because it's just
makes sense
psychologically. It's the part that makes you better.
Okay, so Lord Mott, we'll go to the final question now. Thank you.
Thank you. I have no interest to declare. We will obviously produce a report which will go to government. When we get to that final point, what one or two recommendations would you like to see in that report?
Have you got a question?
After Lord Mott.
Sorry?
It's like a last question after Lord Mott.
Okay then, right, we'll bear that in mind in terms of time.
Do you mind if I ran through 3 or 4 as opposed to 1 or 2, if that's okay? So firstly, I think there's something about leadership and the sort of... My understanding is that in the new DHSE structure, the DG for... the commercial DG for commercial and value will have medicine supply under their remit. Now that's fine, but I think there is something, because of the growing geopolitical risk here, I think there's something about allocating someone as an SRO and being very clear about who's responsible here. Then under that, to sort of establish something like a medicine security board or something like that with the relevant agencies and things on, to be able to where that SRO probably would chair it, in order to just give this the right profile. I mentioned that the Cabinet Office risk documents do not specify medicines supply chain as a specific risk, and it feels to me it needs a bit more profile. I've mentioned supply chain digitisation. We've gone through that to some extent already, so I think there should be an ambition around supply chain digitisation. I've mentioned that the current government do not see stockpiling in any form as a mitigation at the moment. No doubt you'll be questioning the department. I think they're coming next week, I think, aren't they? So I would question them hard. My advice to you is that the government should carry out further risk assessment to sort of understand whether or not some form of stockpiling is in fact necessary now. I think there should be a sort of range of exercises. Medicines security as such is not really a specific part of the exercise programme. It's sort of incorporated into other things around pandemic planning and so forth. So I would call for something a little bit more specific, led by the said SRO. There is a specific issue which we haven't touched on around wholesaling. At that level of the...
What was that, sorry?
What did you say?
Wholesaling. So there are something... To wholesale medicines, you have to have a licence from the MHRA. There are about 1,600 of those in this country. In France, I think there are about 16. So I think there is something here about sort of why is that so different, and looking carefully at the impact that level of licences could have on the supply chain. I've mentioned that sort of the need to sort of develop a list of critical medicines. And I think that's important. And I wonder also whether you should be exploring some form of duty of collaboration. The reason I say that is because during the pandemic, we all worked very well together from within government and outside of government, from within the NHS and outside of the NHS. But it was sort of, it was sort of a spirit of collaboration, as opposed to, I think, at certain times, a duty of collaboration might be something you would want to explore. So I think that's my and those specialist supply chains I mentioned, aseptics and radiopharmaceuticals. I think it would be wise for the committee to seek assurance from the government that the report which Lord Carter chaired is under the previous administration is accepted by the current government and is supported. Because my feeling is the national program is not running as it could. And similarly around radiopharmaceuticals, I think there needs to be a sort of similar sort of exercise which Lord Carter led to sort of examine carefully the needs and the risks associated with radiopharmaceuticals. I think that's my little list of 3 or 4. I hope that
report
helps.
written, right? Dr. Tangra and Paddy.
Okay. I have, I think, 4 specific recommendations today, but I'll try and be quick. The first is, as we've covered in the previous question, to really encourage the government to take on a multi-department friend-shoring exercise. By exercise, I mean not exercise in the sense of like a tier 1 national, but like actually doing it. that I'm heartened to learn that there are teams within DHSC that are engaged with their international colleagues on this front to try and understand what the landscape is and therefore make strategic decisions. I think that needs to become something that is owned by multiple departments and is done in concert with real purpose, in line with the industrial strategy, and to coordinate international industrial strategies. I think that's really key. Secondly is improving data transparency and integration. We've spoken a lot about data today. I would really call on the committee to explore all of the different ways in which data can be better integrated, whether that's funding for biosecurity actors who want to get involved in manufacturing, whether that's manufacturer to patient integration, and whether it's looking again at whether these barcodes that were opted out of following the EU exit was something that we can bring back. I think the data question is key, and I just want to leave you with a very quick anecdote which I've stress tested extensively with a number of stakeholders, and I believe it to be true. There is currently, if we were to consider the smallpox vaccine, which is used among a range of different use cases, there is currently no single person within the UK government, because of a lack of an integrated data platform, that is able to say, these are all of our stocks of smallpox vaccine, this is where they are, this is who holds them, this is when they expire, and this is where the next lot is, this is the ship that it's on and when it's going to land on UK soil. That's a problem. Those stocks are held across civilian and military authorities, so MOD, Home Office, DHSC, UKHSA, all the relevant NHSs. There's some sub-data integration within, for instance, the health agencies speak to each other and have quarterly meetings where they exchange information, and that's great, but that's not real time. That's also siloed from defense. That's also siloed from Home Office that holds some of that stock for counter-terror purposes. There needs to be integration. And of course, as Baroness Cass mentioned, the problem becomes that that's a cybersecurity risk. However, the UK government deals with very serious databases of, for instance, the names of its intelligence agents, and it's able to safeguard those. There's no reason why this couldn't be safeguarded in the same way if it were considered a priority. Then there's the question of stockpiling. I think, again, I'd really echo what Dr. Ridge said. I think that, again, I'm heartened to learn that there is some thinking internally within DHSC about medical countermeasure stockpiles. That's great. We can't see any of it. So as third-party experts, we have absolutely no oversight or scrutiny. Some of that will be national security clearance reasons, and that's fine. That's completely legitimate. However, there's probably more that the government should be able to share with third-party experts in the way that the US government, the Norwegian government, the German government, the French government does. This is not unheard of, and it's something that I think the committee should encourage the government to do, the UK government to do. And the very final thing is public procurement policies, which I think we haven't touched on so much today, but can be used, and I know that there's value-based procurement that's being brought into play by the current government, Value-based procurement is going to have a weighting for continuity of supply. That's a good start. What that will look like specifically and the details will be very, very important to figuring out whether that means multiplicity of supply, how they define continuity, how that interfaces with supply chain resilience specifically. So I think that the committee should question officials as they come in about what that's going to look like, and then make recommendations based on the answers that you receive.
And last one.
And finally, me. Okay, mine is just on the setting boundaries. I'm an operations person, and so setting boundaries is very important. So about the definition of medicine shortage, it's very, very important. And also my colleagues have talked about looking at the data and integration, but we're just talking about stock. We're not looking at demand. The population is changing, and so demand is changing. GPs have data, prescribing data, and even community pharmacies have prescribing data and the demand. It's important to understand that so that we're able to match demand and supply together if we're going to predict and forecast. I will also talk about people. So my first part will be on talking about policy. So policy, unified definition, and data. And I also talk about people. It's important that without people, you can't solve for shortages. So we need to be able to train our pharmacists, train all of our stakeholders on how to address shortages. That is very important. And then practice. This should not be a one-time thing. It should be continuous review because demand is changing. Pharmacy and pharmaceutical supply chain is evolving. And so if we have come up with policies today, we've made recommendations, it shouldn't be a one-time thing. It should be a continuous review of things that happen. Thank you.
That's a good point, thanks. Thank you very much for those. They'll be very helpful. And last question, Lord Bencathra.
Yes. Governments have decided that keeping some aspect of steel manufacturing in this country is a vital national strategic interest. I was concerned recently to read that our big two pharmaceutical giants, AstraZeneca and GSK, may be downscaling investment in Britain and switching it to the United States. That may be short-term ploy pandering to Trump's tariffs or creating a manufacturing base there to avoid the tariffs, or it could be part of a longer trend. If it's part of a longer trend, would you share my deep, deep concern at that? Because it could signal that Britain is downscaling its investment in pharmaceutical manufacturing, and that pulls a rug out of brilliant new startups like Moderna and Oxford Nanopore and stuff like that. It's a loaded question. Do you share my bias?
I'm really going to say a minute each on this one because this could be a whole new inquiry. So really brief, really brief comments. I think that's what we're just looking for here. Thank you.
I'm very happy to.
Okay, my own idea is just the competitive nature. Like I know I said it at the beginning of the process, is that because the UK economy doesn't give them a competitive base, and so they are looking for, because it's all about making money. It's all about profit first before you think about patient care. So a competitive environment is where they will think. And I think in most of their reports, they have talked about that as well. The pricing, it's not very lucrative. And that comes from our pricing strategies, the way we price our product. It's because we are looking for more cost efficiency rather than resilience. And so the balance between those two, we need to find a balance of cost efficiency and resilience.
I think we've already made the argument, I think, that long-term resilience requires pharmaceutical manufacture on UK soil. I mean, I think that for me is the key. As to the movements politically by President Trump and elsewhere, then I think that's slightly sort of different, I think, if you see what I mean. But it would be a sad day if pharmaceutical manufacture, I think, left these shores entirely. Of course, it would be. But from a medicine security resilience point of view, then it seems critical to me that there is sufficient on UK soil.
As a researcher at the Centre for Long-Term Resilience, you will no doubt be unsurprised that I agree with Dr. Ridge on this. I think that you pointed out steel. The reason that steel was specifically chosen and specifically highlighted by the government was as a matter of national security, the continual provision of steel for national security. I think the same applies for continuity of medical countermeasure manufacturing on UK soil.
That goes back to that defence point you made, really, doesn't it? That's been an excellent session. Thank you so much. I think there's been a lot of information and put over in a really clear way. So it's not just been invaluable in its own right. It's been a really good first session, I think, to lay the foundations. We're very grateful for both your time and your expertise. Okay, we'll close formally our meeting, that bit of our meeting.